So now we're going to talk a little bit about how to choose maintenance medications to help manage alcohol use disorder. And if someone is ready for this and interested in treatment, of course, there are psychosocial aspects that should be given as well. But there are some medications that can help maintain someone's goals and improve outcomes. So things that we want to think about: drinking days, total drinking, and harm, right? So we want to try to decrease their total drinking days, decrease their heavy drinking days, number of drinks per day, and of course, improve their quality of life, right? That's at the end of the day, that's all we're trying to do, make their quality of life a little bit better, right? So how do we do that? It depends a little bit on the guidelines that you're looking at or the resources that you're using, but by and large, most guideline producing bodies have agreed upon these as your general levels of recommendation. So our first kind of higher recommendation is naltrexone or camprosate. And these are helpful in reduction in total drinking and heavy drinking days, as well as maintenance of abstinence. Below that is disulfiram. Disulfiram is kind of a mean drug in some ways. We'll talk about why. And it's an option if someone truly prefers to use disulfiram, or if there's significant reasons why they may not be able to be successful in naltrexone or camprosate. From there, we also have topiramate or gabapentin that can be useful in reduction in total drinking as well as abstinence in those who may not be able to tolerate naltrexone or camprosate, or have a strong preference for these products instead. It is important to note that some people will have comorbid things like depression, but medications to treat depression don't specifically have benefit in alcohol use disorder. So things like sertraline are often added, but are not specifically going to confer benefit in reducing alcohol use. Okay, we want to think about benzodiazepines. They are not appropriate to continue specifically for management of alcohol use disorder, but sometimes there may be cases where someone has a good indication otherwise. If they're in recent alcohol use disorder, we usually try to avoid products like benzodiazepines, but it will be determined kind of on an individual basis. So our FDA-approved products are listed here. We've got a camprosate, disulfiram, and naltrexone. So a camprosate or Camprol is a product that is dosed 3 times a day, which is one of the challenges with the product. But it is usually fairly well tolerated, which is nice. Most common adverse effect that we see with a camprosate is diarrhea, so some gastrointestinal stuff. Rare but severe, and it sometimes makes it a little challenging to use in the populations that I tend to work with, is a risk of suicidality and psychiatric changes. So I have seen new onset depression, suicidality with a camprosate, which can, for some people, limit its use. We do have to dose reduce in moderate renal impairment and avoid use in individuals that have pretty significant renal impairment, so creatinine clearance less than 30. Disulfiram or Antabuse is an interesting product, not often used anymore because it's really a behavioral deterrent. So disulfiram works by essentially blocking the body's ability to convert alcohol to vinegar, if you will. So there are some steps in the alcohol metabolism pathway that take alcohol and turn it into vinegar. But there's a middle step that is fairly toxic in the sense that it causes a lot of flushing, it causes vomiting and shaking, and people do not feel good when they have large amounts of the not so good alcohol metabolite in their system. And there's actually some differences in people based on their genetic background. So some people that say they're sensitive to alcohol, so they get flushed and stuff when they consume alcohol, probably have less enzyme that helps to break down the alcohol itself. Other things that we see with disulfiram or Antabuse is taste changes, so things like metallic taste, sexual dysfunction. It can cause dermatitis, sleepiness, headache. Overall, fairly well tolerated, though. Rare but severe, we do see risk of hepatotoxicity, so liver damage. And I haven't seen cases of this, but I know that there have been of what we call optic neuritis, so that kind of swelling of the optic nerve. And individuals who are prescribed disulfiram should be abstinent from alcohol for at least 12 hours before starting and 14 days after discontinuing. There are also places where hidden alcohols may be found. So things like hand sanitizer, some liquid prescription products, mouthwashes. And this is a reaction that's kind of similar to what we see with metronidazole, so just being aware of that. And then naltrexone, so the PO is actually Revia, but we have oral as well as the injection. Okay. So the monthly injection, we do like to get people on. It's fairly convenient to use, but have a lot of people that do well in the oral as well. Fairly well tolerated. Stomach stuff is your most common. Okay. So, but we do sometimes see people feel a bit more run down with naltrexone because it is blocking opioid receptor activation. People can feel more anxious. It does have some rare but severe risk of hepatotoxicity. So we do check LFTs and ensure that that's not going on. It can also precipitate opioid withdrawal because it is an opioid antagonist. So if someone is in need of opioids or uses opioids, then this can precipitate withdrawal. And it's recommended that individuals be free of opioids for 7 to 10 days in order to use the product. Now, if someone has acute liver enzyme elevations or liver failure, we tend to avoid these products. Other things with the injection. So the injection can be a little challenging to administer. The needles get kind of clogged up. It actually comes with multiple needles, and it tends to be a bit more expensive, but a lot of times we can get insurance coverage for it. They will have to go in for monthly injections, but then they don't have to worry about taking a medication every day for their alcohol use disorder, which is a positive. Then, of course, we have our non-FDA approved products. So we have topiramate and gabapentin. So topiramate has some benefit for sure. There are some adverse effects that can be a bit challenging with topiramate. Things like paresthesia, so like tingliness in the extremities. We do see suppression of appetite. We do see some taste disturbances. One of the ones that people report often as a challenging adverse effect with topiramate is this cognitive dulling. So they kind of feel like they can't, almost like they can't find the right words, or they can't keep, like, they have less clarity of thoughts. Sometimes we jokingly refer to Topamax as Dopamax because of that. It has some carbonic anhydrase inhibition that can contribute to that particular adverse effect. And also related to that, increases risk of things like metabolic acidosis. It also has associations with nephrolithiasis, which are kidney stones. So if someone has a history of kidney stones, we usually try to stay away from Topamax as an option unless we've kind of tried everything else. And then oligohydrosis, which is reduction in sweating. And if you titrate it more slowly, then it can improve some of those tolerability concerns. We do keep an eye on things like electrolytes and kidney function or renal function when using that product. And then gabapentin or Neurontin in doses of 9 to 1800 per day. In some states, it is a scheduled substance. In Kentucky, for example, it's a Schedule 5. I believe. And it does have some CNS depressing effects. So we do see sleepiness, fatigue. It can cause headache, upset stomach, usually fairly well tolerated though. It does have some a rare but severe risk of worsening of things like suicidality that we will monitor for, but it's pretty uncommon. And is another renally adjusted product. So if someone has renal impairment, usually the frequency of dosing gets adjusted, as well as, depending on the severity of the renal impairment, the total daily dose. So a lot of times the first thing you do is go to twice a day, for example. So there is that risk of misuse as well. But those are the products that we do. Usually, naltrexone is the first one that we tend to reach for in my practice, as long as someone is not using opioids, or if they have opioid use disorder, then they want treatment for both. That's actually a good thing, but we do have to still wait that 7 to 10 days before we can use that product. Acamprosate does have pretty good tolerability profile. The mental health adverse effects can be challenging, but aren't really common just with the population that I tend to work with in mental health. That's something that happens a little bit more often in that population. And then gabapentin is fairly widely used, but it is not an FDA approved option, but a good alternative option. Disulfiram, as I mentioned, not as commonly used, but some people actually do like to have disulfiram as an option for them because you have to take it every day, and it's almost like they're actively making a choice to take this medicine, knowing that it has that severe reaction with alcohol. So that almost is like a motivator for them. So I have had some people actually like that aspect of disulfiram.